This is Dr. Lyle Jones, Editor-in-Chief of Continuum, the premier topic-based neurology clinical review and CME journal from the American Academy of Neurology. Thank you for joining us on Continuum Audio, which features conversations with Continuum's guest editors and authors who are the leading experts in their fields. Subscribers to the Continuum Journal can read the full article or listen to verbatim recordings of the article and have access to exclusive interviews not featured on the podcast. Please visit the link in the episode notes for more information on the article, subscribing to the journal, and how to get CME.
This is Dr. Teshamae Monteith. Today I'm interviewing Dr. Dave Clarke about his article on diversity and underserved patient populations in epilepsy, which appears in the February 2025 Continuum issue on epilepsy. So why don't you introduce yourself to our audience?
Sure. My name is Dr. Dave Clarke, as alluded to. I'm presently at the University of Texas in Austin, originating from much farther south. I'm from Antigua, but have been here for quite a while. I'm working within the field in epilepsy surgery, but more and more getting involved in outreach, access to care, and equity of healthcare in epilepsy.
And how did you get involved in this kind of work?
That's an amazing question. I did it in a bit of an inside-out fashion. I initially started working in the field and trying to get access to persons in the Caribbean that didn't have any neurological care or investigative studies, but very quickly realized that persons around the corner here in Texas and wherever I've worked have had the exact same problems. Getting access via fiscal or otherwise to epilepsy care, or geographically getting access, with so few having neurologists close at hand. Therefore, I started working both on a regional, national, and it transcended to a global scale.
Wow, so you're just everywhere.
Building bridges. I've found building bridges and helping with knowledge and garnering knowledge, you can expand your reach without actually moving, which is quite helpful.
Yeah. So why don't you tell us why you think this work is so important in issues of diversity, underserved populations, and of course, access to epilepsy care?
Sure, not a problem. And I think every vested person in this can give you a different spiel as to why they think it's important. So I'll add in a few facts pertaining to access, but also tell you about why I think personally that it's not only important, but it will improve care for all and improve what you believe you could do for a patient, because the said thing is to have a good outcome. In the United States presently, we have over 300 epilepsy centers, but they have about 8 or 9 states that don't have any epilepsy centers at all. And even within states themselves, people have to travel up to 8 hours, i.e. in Texas, to get adequate epilepsy care. So that's one layer. Even if you have an epilepsy center around the corner, independent of just long wait times, if you have a particular race or ethnicity, we've found out that wait may be even longer, or you may be referred to a general practitioner more so than being referred to an epilepsy center. Then you add in layers of insurance or lack thereof, which is a big concern. Regardless of who you are, poverty, which is a big concern. And the layers just keep adding on, culture, etc., etc. If you could just break down some of those barriers, it has been shown quite a few years ago that once you get to an epilepsy center, you can negate some of those factors. You can actually reduce time to access and you can improve care. So that's why I'm so passionate about this, because something could potentially be done about it.
That's cool. So it sounds like you have some strategies, some strategies for us.
Indeed. And this is a growth and this is a learning curve for me and will be for others. But I think on a very local one-to-one scale, The initial strategy I would suggest is you have to be a good listener, because we don't know how, when, where, or why people are coming to us for their concerns. And in order to judge someone if they may not have had a follow-up visit, or they may not have gotten to us after 5 medications, the onus may not have been on that person. In other words, as we learned when we were in medical school, history is extremely important, but social history, cultural history, that's also just as important when we're trying to create bridges. The second major thing that we have to learn is we can't do this alone. So without others collaborating with us outside of even our fields, the social worker who will engage, the community worker who will discuss, the translator for language, unless you treat those persons with respect and engage with those persons to help you to mitigate problems, you'll not get very far. And then we'll talk about more, but the last thing I'll say now is they have so many organizations out there, the Institute of Medicine, or the International League Against Epilepsy, or members of the American Epilepsy Society, that have ways, ideas, papers, and articles that can help guide you as to how better mitigate many of these problems.
Great. So you already mentioned a lot of things. What are some things that you feel absolutely the reader should take away in reading your article? You mentioned already listening skills, the importance of interdisciplinary work, including social work, and that there are strategies that we can use to help reduce some of this access issues. But give me some of the essential points, and then we'll dive in.
Okay. I think first and foremost, we have to lay the foundation, in my mind, and realize what exactly is happening. If you are Native American, of African descent, Hispanic, Latinx, geographically not in a region where care can be delivered, choosing one, time to epilepsy surgery, may be delayed twice, 3, 4 times that of someone of white descent. If you are within certain regions in the US where they may have 8, 9, 10, 14 epilepsy centers, you may get to that center within 2 to 3 years. But if you're in an area where they have no centers at all, or you live in the Dakotas, it may be very difficult to get to an individual that could provide that care for you. That's very, very basic. But a few things have happened a few years ago and even more recently that can help. COVID created this groundswell of ambulatory engagement and ambulatory care. I think that can help to mitigate time to get into that person and improving access. In saying that, there are many obstacles to that, but that's what we have to work towards. That virtual engagement and virtual care. That would suggest, in some instances, to some persons, that it will take away the one-to-one care that you may get with persons coming to you. But I guarantee that you will not lose patients because of this, because there's too big a vacuum. Only 22% of persons that should actually get to epilepsy centers actually get to epilepsy centers. So I think we can start with that foundation, and you can go to the article and learn a lot more about what the problems are. Because if you don't know what the problems are, you can't come up with solutions.
Just give us a few of the most persistent inequities in epilepsy care.
Time to seeing a patient, very persistent, and that's both a disparity, a deficiency, and an inequity. And if you allow me, I'll just explain the slight but subtle difference. So we know that time to surgery in epilepsy, in persons that need epilepsy surgery, can be as long as 17 years. That's for everyone. So that's a deficiency in care. I just mentioned that some sociodemographic populations may not get the same care as someone else. And that's a disparity between one versus the other. Health equity, whether it be from NIH or any other definition, suggests that you should get equitable care between one person and the other. And that brings in not only medical, legal, or potential bias that we may have one person versus the other. So there's a breakdown as to those different layers that may occur. And in that, I'm telling you what some of the potential differences are.
And so you mentioned it comes up race and ethnicity being a major issue, as well as some of the geographic factors. How does that impact diagnosis and really trying to care for our patients?
So again, I'm going to this article or going to even prior articles. It has been shown by many, and most recently in New Jersey, that if you're Black, Hispanic, Latinx, it takes you greater than 2 times the time to surgery. Reduced time to surgery significantly increases morbidity. It potentially increases mortality, as has been shown by a colleague of mine presently in Calgary. And independent of that, we don't look at the other things, the other socially related things. Driving, inability to work, inability to be adequately educated, the stigma related to that in various cultures, various countries. So that deficit not only increased the probability of having seizures, but we have to look at the umbrella as to what it does. It significantly impacts quality of life of that individual and actually the individuals around them.
So what are some of these drivers and how can we address them or at least identify them in our clinic?
That's a question that's rather difficult to answer. And not because there aren't ideas about it, but is actually mitigating those ideas or changing those ideas we're just presently trying to do. Although outlines have been given. So in about 2013, the federal government suggested outlines to improve access and to reduce these inequities. And I'll just give you a few of them. One of those suggestions was related to language and having more improved and readily available translators. Something simple. And that could actually foster discussions and time to better management. Another suggestion was try to train more persons from underserved populations, persons of color. Reason being, it has been shown in the social sciences and it is known in the medical sciences that if you speak to a person of similar culture, you tend to have a better rapport, you tend to be more compliant, and that track would move forward and it reduces bias. Now, we don't have that presently, and I'm not sure if we'll have that in the near future, although we're trying. So then, within your centers, if you have trainings on cultural sensitivity, or if you have engagement and lectures about how you can engage persons from different populations, those are just some very simple pearls that can improve care. This has been updated several times with the then Institute of Medicine. In 2012, 2013, they came out with, in my mind, a pretty amazing article, but I'm very biased, in which they outline a number of strategic initiatives that could be taken to improve research, improve clinical care, improve health equity through health services research, to move the field forward and to improve overall care. They updated this in 2020, and it's a part of the 2030 federal initiative, not only for epilepsy, but to improve overarching care. All of this is written in bits and pieces and referenced in the article. To add icing on top, the World Health Organization, through advocacy of neurological groups as well as the International League Against Epilepsy and the AES, came out with the Intersectoral Action Plan on Epilepsy and Other Neurological Diseases, which advocates for parallel improvement in overall global care. And the United States have signed on to it. And that have lit a fire to our member organizations like the American Epilepsy Society, American Academy of Neurology, and others trying to create initiatives to address this care. I started off by saying this was difficult because, we have debated epilepsy care through 1909 when the International League Against Epilepsy was founded. And we have continually come up with ways to try and advance care, but this have been the most difficult and critical because there's social dynamics and social history and societal concerns that have negated us moving forward in this direction. But fortunately, I think we're moving in that direction presently. That's my hope. And the main thing we have to do is try to sustain that.
Yeah, so you talked about the importance of these global initiatives, which is huge, and other sectors outside of neurology, like, for example, technology. You spoke about telemedicine. I think you were referring to telemedicine with COVID. What other technologies that are more specific to the field of epilepsy, some of these monitorings that maybe can be done?
Oh, I was just gonna jump on that. Thank you so much for asking.
I have no disclosures in this field, but I think it's important and exciting to think, how can we increase access and even access to monitoring to some of these technologies? That might be expensive, which is another issue, but.
So the main things in epilepsy diagnosis and management, you want to hear from the patient history. You want to see what the seizures look like. And then you want to find ways in which to monitor those seizures. Hearing from the patient, they have these questionnaires that have been out there. And this is local, regional, global. Many of them standardized in English and Spanish. Our colleagues in Boston actually created quite a neat one in English and Spanish that some people are using. Ecuador has one. We have created something analogous. And those questionnaires can be sent out virtually and you can retrieve them. But sometimes seeing is believing. So video uploads of seizures, especially the cell phone, I think has been management changing for the field of epilepsy. The thing you have to do, however, is do that in a HIPAA compliant way. And several studies are ongoing. In my mind, one of the better studies here was done on the East Coast, but another similar study, to be unnamed, but again, written out in the articles, when you go into these apps, you can actually type in a history and upload a video. But the feed is not only going to you, it may be going to the primary care physician. So it not only helps in one way in you educating the patient, but you educate that primary care physician, and they become extenders and providers. I must add here my colleagues, because we can't do without them. Arguably, in some instances, some of the most important persons to refer patients, that's the APPs, the PAs and the nurse practitioners out there that help to refer patients and share patients with us. So that's the video uploads, that's seeing. But then the other really cool part that we're doing now is the ambulatory world of EEGs. Cerebell, Zeto, to name a few, in which you could potentially put the EEG leads on persons with or without the EEG technologists wirelessly and utilize the clouds to review the EEGs. It's not perfect just yet, but that person that has to travel 8 hours away from me, if I could do that and negate that travel when they don't have monies to pay for travel or they have some potential legal issues or insurance-related issues, and I could read the EEG, discuss with them via telemedicine their care, it actually improves access significantly. I'm going to throw in one small twist that, again, is not perfect. We're now trying to monitor via autonomic features, heart rate, movement, and others for seizures, and alert family members, parents, because although about 100,000 people may be affected with epilepsy, We're talking about 500,000 people who are also affected that are caregivers, affiliates, husbands, wives, etc. Just picture it. You have a child, let's say 3-4 years old, and every time they have a seizure, or not every time, but 80% of times when they have a seizure, it alerts you via your watch, or it alerts you in your room. It actually gives that child a sense of a bit more freedom. It empowers you to do something about it because you can understand here. It potentially negates significant morbidity. I wouldn't stretch it to say SUDEP, but hopefully the time will come when actually it can prevent not only morbidity, but may prevent death. And I think that's the direction we are going in, to use technology to our benefit, but in a HIPAA-compliant way and in a judicious way in order to make sure that we not only don't overtreat, but at the end of the day, we have the patient as number one, meaning everything is vested towards that patient and do no harm.
Great. One thing you had mentioned earlier was that there are even some simple approaches, efficiency approaches that we can use to try and optimize care for all in our clinics. Give me what I need to know. Or give me what I need to do.
Yeah, I'll get personal as to what we're trying to do here, if you don't mind. The initial thing we did, we actually audited care and time to care delivery. And then we tried to figure out what we could do to improve that access and time to care, triaging, etc. A very, very simple thing that can be done, but you have to look at costs, is to have somebody that actually coordinates getting persons in and out of your center. If you are a neurologist that works in private practice, that could potentially be a nurse, being associated directly one-on-one with one of the major centers, a third or fourth level center. That coordination is key. Educate your nurses about epilepsy care and what the urgent situations are, because it will take away a lot of your headache and your midnight calls, because they'll be able to know what to do during the day. Video uploads, as I suggested, regardless of the EMR that you have, figure out a way that a family could potentially send a video to you, because that has significantly helped in reducing investigative studies, triaging appropriately for us to know what patients we can and cannot see. Extenders has helped me significantly, and that's where I learned. So, as stated, there aren't many neurologists and epileptologists, and utilizing appropriately trained nurse practitioners or residents engaging with them equally, and or social workers and coordinators are very helpful. So hopefully that's just some low-hanging fruit that can be done to improve that care.
So why don't you give us some of your major takeaways to how we can improve epilepsy care for all people?
I've alluded to some already, but I like counts of 3s and 5s. So I think one major thing, which in my mind is a major takeaway, is cultural sensitivity. I don't think that can go too far in improving care of persons with epilepsy. The second thing is, if you see a patient that have tried 2 adequately used medications and they're still having seizures, please triage them. Please send them to a 3rd or 4th level epilepsy center and demand that that 3rd or 4th level epilepsy center communicate with you, because that patient will eventually come back and see you. The third thing, I said 3, listen to your patients, because those patients will actually help and tell you what is needed. And I'm not only talking about listening to them medication-wise. I know we have time constraints, but if you can somehow address some of those social needs of the patients, that will also not only improve care, but negate the multiple calls that you may get from a patient.
You mentioned a lot already. This is really wonderful. But what I really want to know is what you're most hopeful about.
I have grandiose hopes, I'll tell you that from the beginning. My hope is when we look at this in 10 years, and studies are done to look at equitable care, at least when it comes to race, ethnicity, insurance, we'll be able to minimize, if not end, inequitable care. Very similar to the intersectoral action plan on epilepsy by 2030. I'll tell you something the plan suggests, and I think it's global and definitely regional. The plan suggests that 90% of persons with epilepsy should know about their epilepsy. 80% of persons with epilepsy should be able to receive appropriate care. And 70% of persons with epilepsy should have adequately controlled epilepsy. 90-87. If we can get close to that, that would be a significant achievement in my mind. So when I'm chilling out in my home country on a fishing boat reading EEGs in 10 years, if I can read that, that would have been an achievement that not necessarily I would have achieved, but at least, hopefully, I would have played a very small part in helping to achieve. That's what I think.
Awesome.
I appreciate you asking me that because I've never said it like that before in my own mind. It actually helped with clarity.
I ask great questions.
There you go.
Thank you so much. I really appreciate your passion for this area and the work that you do. It's really important, as you mentioned, on a regional, national, and certainly on a global level, important to our patients, and even some very simple concepts that we may not always think about on a day-to-day basis.
Oh, I appreciate it. And, I'm always open to ideas. So if others, including listeners, have ideas, please don't hesitate in reaching out.
I'm sure you're going to get some messages now.
Awesome. Thank you so much.
Thank you. I've been interviewing Dr. Dave Clarke about his article on diversity and underserved patient populations in epilepsy, which appears in the most recent issue of Continuum on epilepsy. Be sure to check out Continuum audio episodes from this and other issues. And thank you to our listeners for joining today. This is Dr. Teshamae Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, you'll love the journal, which is full of in-depth and clinically relevant information important for neurology practitioners. Use the link in the episode notes to learn more and subscribe. AAN members, you can get CME for listening to this interview by completing the evaluation at continuumpub.com/audiocme. Thank you for listening to Continuum Audio.